Hello, cataract surgeons. Earlier we spoke on how to introduce your non-dominant hand to the phacosurgeries, starting with easy cases and giving the non-dominant hand some basic tasks. However, after a couple of cases we have to upgrade and give the non-dominant hand some serious tasks. Now this is a 70-year-old male with a significant nuclear sclerosis and possessive capsular cataract, vision blue stain in the capsule, and the non-dominant hand is creating the main wound now using the keratome. Now we're gonna use the non-dominant hand to create rexus, poking the anterior capsule with the obturator forceps and slowly running it at 360 degrees under the viscoelastic protection. Now it seems that this rexus is a little small for this hard nucleus, so I decided to enlarge it. Using the Vanus scissor, I created a cut in the anterior capsule and run that anterior flap around 180 degrees to reasonable size. That helps me complete this phacosurgery. Notice that the dominant hand, in this case the right hand, is only helping the non-dominant hand performing the main tasks. Hydrodissection is going in, no clear fluid wave because the nucleus is thick and the view is not that great. Now the phacoprobe is going in with the non-dominant hand, and the non-dominant hand is actively performing strokes in this the nuclear matter and creating creating 80% thickness groove, and then we're gonna crack it, and there is a 180 degree of crack, and then our horizontal chop, and then another chopping going in the heminuclei, and then some horizontal chops. Now notice that the non-dominant hand is actively doing some serious tasks here, grooving and chopping and emulsifying. The right hand or the dominant hand is helping the non-dominant hand by feeding it the nucleus pieces, and also the non-dominant hand is trying to reach the nucleus pieces, actively running around chasing around the pieces. So as you can see, after a significant number of easy cases, now we can depend on the non-dominant hand and give her some serious tasks. Now remove the epinucleus, and then we're gonna use both hands to remove the cortex. Now the reason we like using dominant and non-dominant hand is, well, it helps you sit superiorly and gives you better leg room and knee room under the patient's table, and it is just great in cases of trauma or severe comorbidity of the patient, or the positioning with patients who have difficult anatomy. So it's always good to have both hands actively working together to complete these surgeries. Everything looks so great now, and polishing and removing the cortex was completed, and now time to inject the IOL. Feeding the IOL to the cartilage, and then filling up the AC with viscoelastic. It did go in, so we're gonna dilate the wound a little bit with the keratome. Now we're gonna inject it to the bag and center it inside the bag using the dominant hand with the dialer or the chopper. Now we're removing the viscoelastic, and then we're gonna hydrate the wounds, and we're gonna inject air bubble. Removing the viscoelastic from behind the optic is also a good skill to learn. Now hydrating the main wound, hydrating the side ports, and then injecting an air bubble.